Why diagnose? For many people, including some therapists, diagnosis is a dirty word. We've all seen the misuse of psychodiagnostic formulations. The complex person gets flippantly oversimplified by the interviewer who is anxious about uncertainty. The anguished person gets linguistically distanced by the clinician who cannot bear to feel the pain. The troublesome person gets punished with a pathologizing label. Racism, sexism, heterosexism, classism, and numerous other prejudices can be, and have often been, handedly forfeited by nosology. Currently in the United States, where insurance companies allot specific numbers of sessions for specific diagnostic categories, often in the defiance of a therapist's judgment, the assessment process is essentially subject to corruption. Just listing the flaws with diagnosis or the reasons why people are hesitant towards diagnosis and therapy. One objection to diagnosing is the view that diagnostic terms are inevitably pejorative. No matter what we do, that they're going to be negative. Paul Watchell recently referred to diagnosis, for example, as insults with a fancy pedigree. Jane Hall writes that labels are for clothes, not people. Seasoned therapists often make such comments, but I suspect in their own training it was helpful for them to have language that generalized about individual differences and their implications for treatment. Once one has learned to see clinical patterns that have been observed for decades, one could throw away the book and savor individual uniqueness. Diagnostic terms can be used objectifyingly and insultingly, but if I succeed in conveying individual differences respectfully, readers will not recruit diagnostic terms in the service of feeling superior to others. Instead, they will have rudimentary language for mentalizing different subjective possibilities, a critical aspect of both personal and professional growth. The abuse of diagnostic language is easily demonstrated. That something can be abused, however, is not a legitimate argument for discarding it. All kinds of evil can be wreaked in the name of worthy ideals, love, patriotism, Christianity, whatever, through no fault of the original vision, but because of its perversion. The important question is, does the careful, non-abusive application of psychodiagnostic concepts increase a client's chances of being helped? Can diagnosis help when done in the right spirit? There are at least 5 interrelated advantages of the diagnostic enterprise when pursued sensitively and with adequate training. Its usefulness for treatment planning, its implications for prognosis, its contribution to protecting consumers of mental health services, its value in enabling the therapist to convey empathy, and its role in reducing the probability that certain easily frightened people will flee from treatment. It's useful for kind of treatment planning, for being able to create the necessary steps to help the person. Its implications for prognosis. What does prognosis mean? Let me Google it. Prognosis is the likely course of a disease or ailment, so its diagnosis can be useful in implicating what the disease might progress into, or just characteristics of the diagnosis, not the disease, the diagnosis. Its contribution to protecting consumers of mental health services. It can help protect consumers. It could help protect the clients if you're able to diagnose. We'll see how she elaborates. It's a value in enabling the therapist to convey empathy. Diagnosis will help convey empathy and its role in reducing the probability that certain easily frightened people will flee from treatment. Maybe diagnosis helps people not flee if they're, maybe more worried people. By the diagnostic process, I mean that except in crises, the initial sessions with the client should be spent gathering extensive and objective and subjective information. My own habit is to devote the first meeting with a patient to the details of the presenting problem and its background. At the end of that session, I check on the person's comfort with the prospect of our working together. Then I explain that I can understand more fully if I could see the problem in a broader context. And I get agreement to take a complete history during our next meeting. I like that. First session to examine the issues at hand, form some sort of familiarity. And the next session to do a more deep dive, more procedural, deeper questions about the full picture of the person's life, even of factors that might not be necessarily on the surface level relevant to the presenting problem. In that session, I reiterate that I'll be asking a lot of questions, requested permission to take confidential notes, and say that the client is free not to answer any question that feels uncomfortable. This rarely happens, but people seem to appreciate the comment. I am unconvinced by the argument that simply allowing a relationship to develop will create a climate of trust in which all pertinent material will eventually surface. Once the patient feels close to the therapist, it may become harder, not easier, for him or her to bring up certain aspects of personal history or behavior. Alcoholics Anonymous meetings are full of people who have spent years in therapy or consulted a bevy of professionals without ever having been asked about substance use. For those who associate diagnostic session with images of authoritarianism or holier-than-thou detachment, let me stress that there is no reason an in-depth interview cannot be conducted in an atmosphere of sincere respect and egalitarianism. I myself have a pushback against the more clinical, in-depth interview. So this is good for me to hear. Patients are usually grateful for professional thoroughness. One woman I interviewed who had seen several previous therapists remarked, "No one has ever been this interested in me." Psychoanalytic diagnosis versus descriptive psychiatric diagnosis. Even more than when I write the first edition of this book, Psychiatric Descriptive Diagnosis, the basis of the DSM and ICD systems, has become normative. So much so that the DSM is regularly dubbed the Bible of mental health, and students are trained in it as if it possesses some self-evident epistemic status. Although inferential, contextual, dimensional, subjectively attuned diagnosis can coexist with descriptive psychiatric diagnosis, the kind of assessment described in this book has become more the expectation than the rule. I view the state of affairs with alarm. Although the inferential, contextual, dimensional, subjectively attuned diagnosis, although my natural feeling, subjective diagnosis that I feel can coexist with the DSM, the kind of assessment described in this book has become more the exception than the rule. It's more rare, she feels, that people find that coexisting balance of the subjectively feeling, present moment diagnosis in the DSM. I guess she suggests that these things are more rare to happen, and that's alarming to her. Let me mention briefly, with reference to the DSM, my reservations about descriptive and categorical diagnosis. Some of these may be quieted when the DSM-5 appears, but I expect that the overall consequences of our having deferred to categorical trait-based taxonomy since 1980 will persist for some time. First, the DSM lacks an implicit definition of mental health or emotional wellness. Psychoanalytic clinical experience, in contrast, assumes that beyond helping patients to change problematic behaviors and mental states, therapists try to help them to accept themselves with their limitations and to improve their overall resiliency, sense of agency, tolerance of a wide range of thoughts and affects, self-continuity, realistic self-esteem, capacity for intimacy, moral sensibilities, and awareness of others as having separate subjectivities. I like this definition of mental health. I believe this is very important in my own practice and in my life to reflect upon what mental health really means. So I took note of this part. I'm going to read this again. This is the description of mental health. Accepting themselves with their limitations to improve overall resiliency, sense of agency, tolerance of a wide range of thoughts and affects, self-continuity, realistic self-esteem, capacity for intimacy, moral sensibilities, and awareness of others as having separate subjectivities. Very nice. Because people who lack these capacities cannot yet imagine them, such patients rarely complain about their absence. They just want to feel better. People more in survival mode dealing with large issues at hand may not even realize that these other things are lacking in their life, yet it's important for therapists to have a maybe more complete picture of mental health in order to kind of water these seeds in people. They may come for treatment complaining of a specific Axis 1 disorder, but their problems may go far beyond those symptoms. Second, despite the fact that a sincere effort to increase validity and reliability inspired those additions, the validity and reliability of the post-80s DSM has been disappointing. The attempt to redefine psychopathology in ways that facilitate some kinds of research has inadvertently produced descriptions of clinical syndromes that are artificially discrete and fail to capture patients' complex experiences. She feels that the DSM has been shifted the attempt to redefine psychic mental problems into ways that facilitate some kinds of research, that some research designs have shifted our own definitions. The research, the way the research is designed has shifted the way we define mental issues, mental energetic blocks, problems. And by doing so, it's failed to capture people's experience. While the effort to expunge the psychoanalytic bias that has pervaded the DSM is understandable now that other powerful ways to conceptualize pathology exist, the de-emphasis on the client's subjective experience of symptoms has produced a flat, experience-distant version of mental suffering that represents clinical phenomenon about as well as the description of a key, tempo, and length of a musical composition represents the music itself. Bars. That the DSM has reduced the description of these things into a flat, experience-distant version of mental suffering. It's like listing out the key of a song, the notes of a song, versus the experience of the song itself. That maybe the DSM is lacking the magic of the real quality, the qualia of these mental suffering things that could be, that sound of the song is very, very important to understanding the song. So this could be a flaw in the current way we diagnose, according to her. This critique applies especially to the personality disorders section of the DSM. But it also applies to the treatment of experiences such as anxiety and depression, the diagnosis of which involves externally observable phenomena such as racing heartbeat or changes in eating and sleeping patterns, rather than whether the anxiety is about separation or annihilation, or the depression is anaclitic or introjective. Very interesting that anxiety is either about separation or annihilation, or depression is anaclitic or introjective. Anaclitic. Anaclitic depression. Anaclitic depression versus introjective. Anaclitic depression centers on relational fears like loneliness, abandonment, and dependency, shame-based, stemming from early loss. While introjective depression focuses inward on self-criticism, guilt, and worthlessness, guilt-based, driven by unattainable standards. Anaclitic depression is more shame-based. I'm lonely, abandoned, and dependent. While introjective is self-criticizing, guilt-driven, guilt-based, and feelings of worthlessness. Third, although the DSM system is often called a medical model of psychopathology, no physician would equate the remission of symptoms with the cure of disease. The reification of disorder categories, in defiance of much clinical experience, has had significant unintended negative consequences. Reification. The process of treating an abstract concept, idea, or relationship as if it were a concrete material thing, often leading to misunderstanding or fallacy. The reification of disorder categories. Treating disorders categories as a concrete material thing, leading to misunderstanding. In defiance of much clinical experience, has had significant unintended negative consequences. The assumption that psychological problems are best viewed as discrete symptom syndromes has encouraged insurance firms and governments to specify the lowest common denominator of change and insist that this is all they will cover, even when it is clear that presenting complaints are the tip of an emotional iceberg that will cause trouble in the future if ignored. Insurance companies using this analytical scalpel to rob the magic essence of a person's psyche and reduce it to something very meticulous, therefore robbing the full coverage of a person, shows how this rational scalpel-like analyzing mind can at times come in conflict with the more maybe magical process of therapy. That insurance will specify the lowest common denominator of change and insist that this is all they will cover. They'll only cover this tiny little sliver of the experience of the maybe progress as associated to this presenting problem, and absolutely ignore and not cover the whole emotional iceberg that's underneath just the tip of the presenting issue. And that this whole iceberg will absolutely cause trouble in the future if it's ignored. The categorical approach has also benefited pharmaceutical companies who have an interest in an ever-increasing list of discrete disorders for which they can market specific drugs. Pharmaceutical companies have an interest in increasing the list of disorders, an interest in really measuring out and defining these specific things in a certain descriptive, measurable way so that they could create drugs to target these things and market these things to create more money. Fourth, many of the decisions about what to include in post-1980 DSM and where to include it seem in retrospect to have been arbitrary, inconsistent, and influenced by contributors' ties to pharmaceutical companies, that the DSM writing itself is tied to big money pharmaceuticals. For example, all phenomena involving mood were put in the mood disorders section, and the time-honored diagnosis of depressive personality disappeared. The result has been the misperception of many personality problems as discrete episodes of a mood disorder. Another example, if one reads carefully the DSM descriptions of Axis 1 disorders that are seen as chronic and pervasive, it is not clear why these are not considered personality disorders. Even when the rationale for including or excluding a condition is clear and defensible, the result can seem arbitrary from a clinician's perspective. Even when the rationale for including or excluding a condition is clear and defensible, the result can seem arbitrary from a clinician's perspective. Even when the rationale for including or excluding a condition is clear and defensible, the result can seem arbitrary from a clinician's perspective. From the DSM-3 and on, a criterion for inclusion has been that there is to be research data on a given disorder. This sounds reasonable, but has led to some strange results. While there was enough empirical research on dissociative personalities by 1980 to warrant the DSM category of multiple personality disorder, later renamed dissociative identity disorder, there was very little research on childhood dissociation. And so, despite the fact there was a wide agreement among clinicians who treat dissociative adults that one does not develop a dissociative identity without having had a dissociative disorder in childhood, there is, as I write this in 2010, no DSM diagnosis for dissociative children. I wonder if there's one now. There are specific diagnoses for dissociation in childhood, primarily dissociative identity disorder, along with other disorders like amnesia, depersonalization, derealization, often stemming from severe trauma. Tools like the child dissociative checklist help identify symptoms in kids, which could look like spacing out, amnesia, or unusual imaginary friends, are often misdiagnosed as attention or conduct issues. That's just Google AI. Clinicians use specific screening tools like child dissociative checklists for children aged 6 to 15 to identify these signs. And so, despite the fact that there's a wide agreement among clinicians who treat dissociative adults that one does not develop a dissociative identity without having dissociative identity in childhood, there is no DSM diagnosis for dissociative children. In science, naturalistic observation typically precedes testable hypothesis. New psychopathologies, internet addiction, especially to pornography, a version of compulsivity unknown before technology permitted it, are observed by clinicians before they could be researched. The dismissal of clinical experience from significant influence on post-1980 editions of the DSM has created these kinds of dilemmas, denying more subjective experience in the post-1980 DSM versions. Finally, I want to comment on subtle social effect of categorical diagnosis. It may contribute to a form of self-estrangement, a reification of self-states for which one implicitly disowns responsibility. I have social phobia is a more alienated, less self-inhabited way of saying I'm a painfully shy person. We could use these diagnoses to alienate ourselves and disown responsibility, a sense of agency in our mental suffering. I have a social phobia as more alienated and less self-inhabited way of saying I am a painfully shy person. You're more owning these things, and they're more within you and more intimate to you when you're able to describe them. And I am a more painfully shy person than saying something more clinical or seemingly there's some sense of alienation, and I have social phobia. When its patent on Prozac expired, Eli Lilly put the same recipe into a pink pill and named it Seraphim, and created a new illness, premenstrual dysphoric disorder, PMDD. Many women become irritable when premenstrual, but it is one thing to say, "I'm sorry, I'm kind of cranky today, my period is due," and another to announce, "I have PMDD." It seems to me that the former owns one's behavior, increases the likelihood of warm connection with others, and acknowledges that life is sometimes difficult, while the latter implies one has a treatable ailment, distances others from one's experience, and supports an infantile belief that everything can be fixed. That the belief that everything can be fixed is infantile. Very deep. Very interesting, Nancy McWilliams. I'll read the sentence again. Seems to me that the former owns one's behavior, increases the likelihood of a warm connection with others, and acknowledges that life is sometimes difficult, while the latter implies that one has a treatable ailment, distances others from one's experience, and supports an infantile belief that everything can be fixed. Maybe this is just my idiosyncratic perspective, but I find this inconspicuous shift in communal assumptions troubling. That this whole societal shift of perspective is troubling. Treatment planning. Treatment planning is the traditional rationale for diagnosis. It assumes parallel between psychotherapy and medical treatment. Assumes a parallel between psychotherapy and medical treatment. And in medicine, the relationship between diagnosis and therapy ideally is straightforward. This parallel sometimes obtains in psychotherapy, and sometimes it does not. It is easy to see the value of a good diagnosis for conditions for which a specific, consensually endorsed treatment approach exists. Examples include the diagnosis of substance abuse. Implication makes psychotherapy contingent on chemical detoxification rehabilitation. And bipolar illness, implication provide both individual therapy and medication. Although a number of focused interventions for characterological problems have been developed over the past 15 years, the most common prescription for personality disorders is still long-term psychoanalytic therapy. But analytic treatments, including psychoanalysis, are not uniform procedures applied inflexibly, regardless of patient's personality. She's saying for intervening for therapy interventions on characterological problems. The most common prescription for personality disorders is still long-term psychoanalytic therapy. Therefore, personality disorders, rather than more new clinical interventions, the most effective and most broadcast suggestion is still long-term psychoanalytic therapy, psychoanalysis. But analytic treatments, including psychoanalysis, are not uniform procedures applied inflexibly regardless of a patient's personality. Psychoanalysis itself is more dynamic and more creative and more unique to the person itself, has a lot more live variables, such as like the therapist connection, personality, the rapport between the two, than like a list of inflexibly applied things. Even the most classical analysts will be more careful of boundaries with a hysterical patient, more pursuant of effect with an obsessive person, and more tolerant of silence with a schizoid client. Efforts by a therapist to be empathetic do not guarantee that what a particular client will experience is empathy. One has to infer something about the person's individual psychology to know what can help him or her feel known and accepted. Advances in the understanding of people with psychotic disorders and borderline conditions have led to treatment approaches that are not classical analysis but are rooted in psychodynamic ideas. To use them, one must first recognize one's client as concurrently struggling with psychotic or borderline states, respectively. It is common for research purposes to define therapies, analytic and otherwise, as specific technical procedures. Therapists themselves, in contrast, may define what they do as offering opportunities for intimate new emotional learning, in which technique is secondary to the healing potential of the relationship itself. Analytic therapies are not monolithic activities foisted in a pro-Christian way on everyone. A good diagnostic formulation will inform the therapist's choices in the crucial areas of style of readiness. A good diagnostic formulation will inform the therapist's choices. A true good diagnosis will help the therapist in these crucial areas of style of relatedness. How does this client relate to me? By having a good diagnosis, I could see how this client, what techniques, what ways I could angle myself so this client can relate to me. The tone of the interventions. What is the tone of the interventions I should choose to meet this person where they're at? The topics of initial focus. These things will give me an in to go deeper based on this person's personality. If I diagnose this person's personality correct, I could find out all these things just by the diagnosis. With the increased practice of cognitive behavioral therapy, CBT, we are starting to see approaches to working with serious disturbances of personality that have been developed by practitioners of that orientation. In response to their own clinical experiences with individuality and complexity, CBT clinicians are now writing about case formulation for largely the same reasons I did. I hope this book will be useful to them as well to my psychoanalytic colleagues. Prognostic implications. The practitioner who expects from a patient with an obsessive character the same rate of progress achievable to a person who suddenly developed an intrusive obsession is risking a painful fall. An appreciation of differences in depth and extensivity, personal problems. An appreciation of differences in depth and extensivity of personality problems benefits the clinician as well as the patient. The DSM categories sometimes contain implications about the gravity and eventual prognosis of a particular condition. The organization of information along axis was a move in this direction, but sometimes they simply allow for consensually accepted classification with no implicit information about one could expect from the therapy progress. That a positive diagnosis could really color our whole outlook on these things. That the diagnosis kind of gives us a framework for the energetic structure within a person. And if we can congruently match the puzzle piece from our diagnostic knowledge to that puzzle piece in the person, it kind of gives us this whole shape, and we could see keyholes and maybe blockages. Shine a lot of light on this just by having a diagnosis. The main theme in this book is the futility of making a diagnosis based on manifest problems alone. The main theme in this book is the futility of making a diagnosis based on the manifest problem alone. That is a small, shaky foundation to have a diagnosis based on just the manifesting problems. A phobia in someone with a depressive or narcissistic personality disorder is a different phenomenon from a phobia in a characterologically phobic person. One reason psychodiagnosis has been a bad name in some quarters is that it has been done badly. People simply attached a label to a patient's presenting complaint. It is also impossible to do good research on different diagnostic entities if they are being defined strictly by their manifest appearance. It is also impossible to do good research on different diagnostic entities if they are being defined strictly by their manifest appearance. As with any computer analysis, if garbage goes in, garbage comes out. A strength of psychoanalytic tradition is its appreciation of the differences between a stress-related symptom and a problem inhering in personality. This was not always true. Freud originally made few distinctions between characterologically hysteric individuals and people with other psychologies who had hysterical reaction, or between what would now be considered an obsessive person at a borderline level of functioning and a person with obsessional neurosis. The bulimic woman who develops her eating disorder as a first-year college student and who recognizes her behavior as driven and self-destructive is a very different patient from the woman who has a binge purge cycle since elementary school and who considers her behavior reasonable. Both would meet the DSM criteria for bulimia, but one would reasonably expect the first client to change her behavior within a few weeks, while a realistic goal for the second would be that after a year or so, she would clearly see the costs of her eating disorder and the need for change. All right, so maybe will be where I stop for now. And I really like this book so far, very thorough. The point of this reading is to make myself a better therapist, and I seemingly really respect her thoroughness of thought and ability of English language to really lay out these ideas with lots of nuance, to really walk you through the things. The main point of this book is the futility of making diagnosis based on the manifest problem alone. This is here to help you diagnose in the most professional and health, life-affirming way of really seeing that the tip of the iceberg, the presenting problem, the reason people come to therapy, does not necessarily color everything, that often this is just the tip of the iceberg, and understanding the iceberg of the personality really can help us make a much better diagnosis and really kind of paint that full picture to find these different keyholes and blockages within the energetic structure of a person. This is how I understand it. I really like this example, about the bulimic woman as a first-year college student. If we were to list out just the presenting issues, both these people experiencing bulimia at the same time, it might look exactly similar, but understanding the personality, maybe more the energetic structure of how the energy kind of has been and shaped over their lifetime, we could much more realistically kind of see the goals and the outlooks for these people. It's also really cool to see her kind of reflection upon how insurance and pharmaceutical companies kind of influence these things, how the DSMs change over time, and how her kind of reflection upon the changing attitudes of society and how we as a society interact with these labels. Very thoughtful, and I'm excited to read more.